All right, hello everyone, and welcome to our latest Emergency Manuals Implementation Collaborative webinar. Thank you all for joining us today. My name is Jim Sachetta. I'm a digital strategist at Ariadne Labs and a longtime steward of the OR crisis checklist at the lab. I'll be your co-host for today's event. It's my pleasure to introduce to you my co-host, Dr. Alex Hannenberg, who will be leading the webinar with me today. Alex is faculty member in the Safe Surgery, Safe Systems program at Ariadne Labs, and his work is focused on the implementation of crisis checklists for critical event management in the operating room and beyond. He is also a past president of the American Society of Anaesthesiologists. And finally, we're very excited to be joined today by Dr. Michael St. Pierre. Dr. St. Pierre is associate professor in the Department of Anaesthesiology at the University Hospital in Erlangen, Germany. Welcome, Dr. St. Pierre. We're very excited to have you with us here today. Now, before we start, I'd like to just take a few minutes to run through some Zoom information with you all. We're going to be keeping the phone lines on mute to cut down on any background noise. We would greatly appreciate it if you could all maintain your lines on mute. If you have any questions or comment at any point during the call, you can either type them into the chat function or use the raise your hand function that's located in the participant box. If you raise your hand, we can call on you so that you can ask your question out loud. I will also be available throughout the webinar to answer any questions, and you can direct them through the chat box, and I'm also happy to direct anything to our speaker. If at any point you have any technical questions or concerns, please use the chat to host function, and I'll be able to also assist you directly. And lastly, just a reminder that we are recording this webinar to make it available on the EMIC website to those who couldn't join us live today. Now, I'd like to just quickly take a minute to recap what EMIC is to any new participants on the webinar today. EMIC was founded nearly a decade ago with the goals of providing free tools and resources, frameworks and guides for implementation, and a community to support the adoption and use of emergency manuals around the globe. We have grown to a community of nearly 600, and we continue to compile resources that are available to all on the EMIC website. We also maintain an implementation toolkit that can also be found through the site. And if you haven't joined already, we welcome you to join the collaborative through a simple form that's available on the site. By joining, you'll gain access to invitations to future webinars like this, as well as updates on tools and resources, and also invitations to future in-person events. I'll now pass things over to Dr. Alex Hannenberg to get us started.
Thank you, Jim. Excited for this conversation. I have myself about 1 million questions for Dr. St. Pierre. We'll get to a small fraction of them, but this is also a good opportunity to pause and recognize Jim for his stewardship of this group since before the beginning. We all owe a lot to him. As he mentioned, our presenter today, Dr. Michael St. Pierre, is on the faculty at the University Hospital in Erlangen. He is associate professor there, and his research focuses on patient safety and human factors related topics. In addition to his medical and anesthesiology training, he's done graduate work in human factors, patient safety, and simulation at the University in Lund, Sweden. And he has authored several books in the areas I mentioned. Dr. St. Pierre is also largely responsible for the implementation of a critical incident reporting system for German anesthesia practices about a decade ago. But for the purposes of today's discussion, most relevant is his role as project leader of the German Cognitive Aid Working Group that developed the German National Digital Cognitive Aid for Crisis Management in Anesthesia, which we call eGENA, which is freely available for download. So welcome and thank you for joining us today. I think there's a very high level of interest around the world in the work that you and your colleagues have done. And maybe we can start by asking you to describe the origins of the German Cognitive Aid Working Group.
So first of all, thank you very much for actually inviting us and me as speaker of the working group to this webinar, Alex. We're quite grateful, and actually humbled because looking through the list of names that appeared as visitors, there are some names which who have published a lot of work before we actually started it and where we profited a lot from it. So the German Cognitive Aid Working Group is actually a group which was formed just for the purpose of developing this cognitive aid. It all started actually 7 years ago when a company involved in risk management in healthcare approached the German Professional Association of Anaesthesiologists and said that they would like to fund a research project with some visible outcome, not just research. And they asked us whether there was any hot topic in anesthesia which we could actually address. And at that time, we had done some research on a browser-based cognitive aid, which we had published. And when that phone came, I actually was reminded of this quote from David Garber from 2013, Anaesthesiology in his editorial, when he said, actually, it's unbelievable that no international body has attempted to create a more comprehensive set of perioperative cognitive aids through this formal consensus approach. And we said, well, maybe this would be the opportunity for the first national society actually to try whether or not we could accomplish such a task. So it was an initiative of our professional association and also the German Society of Anesthesiology and Intensive Care. We had a small research grant actually for those 4 years. And we finished the project in 2020. And the project members were actually a group of researchers from different university hospitals, all of them with an interest in human factors and patient safety, and all of them affiliated with the simulation center, because from the start we planned to do some sim studies as part of the user-centered design process, which should underlay actually the entire development. And this part actually should be responsible for the medical part and for the input of how we anesthetists actually work. We had a human factors engineer who had previous experience in the UCD process of app development, who was a great help and did a fantastic work together with 2 or 3 postdocs. And then we had a senior training pilot from a commercial airline who helped us to understand the logic of actually using checklists in aviation, and more important, how to actually train young flight students or novice pilots how to use it. And finally, there was a company, a commercial IT company, who programmed the app and who is still hosting the app. So this was the challenge we had, and the aim was we wanted to have a nationwide implementation. From what we knew at that time, only a few hospitals scattered across the country actually had tried to implement paper-based manuals, checklists. So we said, why not try to really kickstart a big initiative? And of course, if you have to pay for something, you won't try it. So actually everything had to be free, the software, the registration, and also the educational material, because we knew it would not make much sense just to say, hey guys, here's a new app, without at the same time offering ample teaching material so that people just could download it and make their training sessions for the nurses and anesthetists. And of course, we also planned some kind of implementation research. What happens when the rubber hits the road? How do the experiences of people actually using it correlate with the hopes and thoughts we had when actually creating the application? So we had a wish list in 2017. The first was it should be actually intuitive to handle. It should be felt by the anesthetist that this is the way how I do my work and actually helps me in every aspect. We wanted to be not platform specific. Otherwise, you open the app and you suddenly receive the message, unfortunately, the developer forgot to update it, so you can't use it. It should work on any device and with any operating system. It should be available offline, because a lot of our ORs have a bad internet connection or mobile phone connection. The medical content should be in accordance with guidelines if available. And we wanted to allow users to edit locally relevant information. The things when we had those emergency pocket manuals, we used to scribble on pages. that one person in charge of this app actually could write in all the information, and everyone in the hospital could just download it and use it. One idea we had to demystify soon because we wanted to have an automatic dose calculation, and we realized that this would be, then the app would actually fall under the medical device law, and this would have been a huge amount of investment and documentation. So we said we only can offer tabs where the user actually has to look weight and the recommended dosage. We knew that experts and novice anesthetists think differently and work differently. And we assumed that the novice group would be the group of anesthetists actually using the app more often. But if you don't get the expert anesthetist in the boat, if you don't have your senior physician telling you, well, that's a good thing, let's check it, let's open it and go through the items, did we miss anything, we would be lost. And it would only be a nice gadget for the young physicians, which they have on their smartphone. So the app actually should support the way experts and novices work. And what we wanted to prevent is actually that you have this anesthetist looking down on his smartphone, autistic, just reading through it. No one knows what goes through his or her head. And then he or she says something and the rest of the team is left outside, and that the doc goes solo. So we said, well, the initial version should actually support teamwork, which means actually being able to be displayed on a tablet or on a landscape PC screen, so the entire team could just group around and go through the items and say, where are we? We think about that with this being an option. When the team, the cognitive aid working group met, we said, well, all of us have the great opportunity of being able to have regular simulation training, but throughout the country, many hospitals hardly ever have heard anything about crew resource management, team resource management. So why not try to actually give them some very basic thoughts about what, besides the medical content, could be important to actually manage efficiently. So we had a Delphi process of finding out which would be the most important CRM aspects we would like to have implement. And as I will show you later, actually when you open the app, you will read them. And from the literature, we knew by then 80 to 90% of all users are actually people sitting down during a calm period of anesthesia and saying, well, let's go through the app. And we had hoped that if they open therapy or diagnosis or other immediate measures, and they would read these CRM items, maybe over the time, they would actually learn these items by heart without having been to a simulation. And last but not least, we wanted to actually provide educational material, and this is also freely available on the websites. So this is as a first short introduction what the Cognitive Aid Working Group is, on what our thoughts were when we started 5 years ago.
Remarkable summary. Now, I'm noticing that you date the launch of this in 2017. At that time, there were a considerable number of operating room cognitive aids around the world, including an excellent one published by the European Society of Anaesthesiologists. So what was it about the existing cognitive aids that motivated you to create something pretty much from a blank slate?
So first of all, if you don't live in a country where you speak English, you have to start from the scratch, either by trying to translate available cognitive aids. And I know that there were some people who had actually translated the Stanford manual, also your Ariadne lab manual. You had people translating the manual from the ESA, and also I think Orschel's anesthetic crisis manual, someone actually translated into German. So first of all the existing cognitive aids were a great inspiration for us. And I don't know where we would have been, or where we would be with eGENA if we wouldn't have had the possibility to read and study all the work you had done before. I think we never had the idea of creating a paper-based cognitive aid for several reasons, because the shortcomings of available paper printed manuals actually encouraged us to pursue this digital goal. And for us, the shortcomings were that we found that they were too static. You have the print pages and you have to page through the manual to find where you have to go. And if you can't just jump from one emergency to another, just accessing a link. We found also that the available cognitive aids were too unspecific, because as anesthetists, we know that context matters. And it makes a great difference in an emergency whether the patient is awake or whether he's anesthetized, whether he's hemodynamically stable or unstable. And if you access or you use emergency manual and you have a patient in the recovery room and there is no item addressing A and B, you say, well, why do I have to start first by memory items and then continue with the checklist? Doesn't make sense. Or the other way around, if you have an anesthetized patient and the manual tells you, please secure the airway, you say, well, no, I've done that already. And I think if you do that too often, the danger is that you start thinking, oh, well, I can just skip that. And what we don't want is that people just skip items. We wanted to have them actually go through all of them because they were context specific enough. We had great discussions whether a linear or branch approach would be ideal. And we found that a linear checklist would be too prescriptive, because it tells you to start at the beginning. Again, if you start in the middle, how do you know where to start? And we found that it's very difficult to actually tell a clinician how to address an emergency. And we thought, we actually don't know where the clinician is at the moment when he opens the app. So he or she should be able to just jump to this part of information he or she actually wants to know. We also thought that if you take the term cognitive aid, just providing you with information concerning therapy would be too narrow in scope. We thought it should help memory plus decision-making plus differential diagnosis plus maybe also helping your teamwork. Our image was always like having a senior anesthetic colleague next to you at 3 o'clock in the morning when you're just dead tired and telling you, well, did you think about that? Could that be an option? Or never mind, the dosage of this drug is this and this. Just to have you encouraged and knowing, okay, if I access this, then it's like having a senior colleague with me. And considering the basic conviction of human factors engineering that it's important to make it easy to do the right thing, we thought paper-based manuals are too much work for the user or for the 1 or 2 local champions who have to print, bind, laminate all the manuals, and also who have to update it from time to time. So we thought it might be a nice idea if this is done by us. And whenever you open the app, they check if or not there's any new information, and you're automatically updated to the most current version. Again, taking the work away from the people at the sharp end and just providing them with a solution that works and it's helpful. So yeah, that would be the reasons why we thought it might be a good idea to start creating a digital version from the scratch.
Right. So and in a moment, give you the opportunity to give us a quick little tour. Mm-hmm. But as you're doing it, I'm going to be thinking about whether the advantages of being able to have a cognitive aid in front of you that is quite specific for the nature of the patient and, as you say, the context, and the trade-off between whatever technical challenges there may be in accessing it, because you can say some things about paper cognitive aids, but the time and potential failure of pulling a book off the shelf is pretty minimal. So let's do two things, if you don't mind. Give us a quick tour of some of the key features, and then I'm going to ask you about the evaluation of the user experience, whether the goals that you have just described for the working group have been realized, or how you know whether they've been realized or not. If that's okay with you, why don't you go ahead and start and show us a little bit about the cognitive aids. It may be that some of the people on the webinar have accessed it already, but for those who haven't, I think it'll be fun to see, look under the hood, as we say. Thank you.
With great pleasure. So first of all, eGENA, which is, as you said, an acronym for cognitive aid for crisis management anesthesia, is a progressive web application, meaning that you won't find it on Android or Google Play Store. It's a functionality supported actually by all modern browsers. And if you open Twitter or Spotify, those are all progressive web applications. They look and feel like an app. They have the functionality, but they have the ease of a browser. So all you need is a browser, a modern browser, and you have no technical problems. So you shared already a PDF with all the data where to find it. And just for the purpose of this webinar, we created an English test version to give you a hands-on experience on how this actually works and how it feels. The German version is much, much larger. Okay, and the nice thing is, I don't know whether you have already installed a progressive web app. You open it for the first time, then the browser appears, and then you add it to your home screen or install on the PC with this comment, and then you have it on your desktop or on your home screen. And the next time you open it, it looks the same, but it no longer has this browser column. So what are the key features? So as you can see from the pictures, it works on every device with any system. And depending whether you have landscape or the small smartphone version, the icons and the architecture is a little bit different, but you can recognize the important thing. And just to note, the only instruction you ever need to operate is this line. Please first select the patient type on the left and then a search option. And from the feedback we receive from many, many users, the rest is actually self-evident. And this is one of the things we actually appreciate very much from this user-centered design process. Quite apparently, we managed to create something where everyone says, I don't need an introduction how to use it. I find my way through it because I know how to operate smartphone or PC. As I said, we as clinicians work differently. And this is also a difference to an emergency manual. You have one size has to fit all. But we thought, no, actually, people might have different approaches on how they want to access information. So if you have chosen either a child, an adult, or parturient, you have those 4 options. Actually, you say, okay, I have resuscitation. I need something with patient cardiac arrest. You can choose that. Or you say, no, I'm actually someone who knows already what the emergency is. Then you have an alphabetical search. Or you say, I'm not quite sure. I think this patient has a B problem, but I have difficulty imagining what it could be. So you go on the B problem and you have the list with all the emergencies where a B problem is part of the emergency. And then others, more graphic-oriented people say, well, actually, I'm like a body navigator. So I go in the lung or in the heart or whatever you want. So this was one way of actually saying you can have different ways of finding the emergency. Plus, you can have a keyword search if you have a specific problem you're looking for. Then, of course, as I said, the main difference is that we try to help the user find the patient he's standing in front of, meaning that it's important to help you find a patient, whether he's awake or anesthetized. And every emergency has, in the German version, has these twofold approaches. You can take the patient who's in a recovery room or on ward, or one who is already an anesthesia. And of course, here the pulmonary embolism, the guidelines make a great difference in diagnosis and therapy, whether or not a patient is hemodynamically stable. And of course, it's much easier, or it's only feasible with a digital version to say, okay, I have a stable or unstable patient where I suspect it, and then you go there, and then you have the part of the guideline which tells you how to proceed. What you can see too is that you always have this color coding with the therapy, and this color coding corresponds to the A, B, C, D, E problem. So at the same time, when you start working on the patient, you always address the A problem first, then the B problem, and then the C problem, and the color just helps you reminding what you're doing right now. Contest. Then, of course, you have the option to actually access other pages. So if you are in a resuscitation and you start and you have from an asystole, suddenly a patient has a rhythm again, you just can switch. Or if the patient has a ROSC, then you can go to the post-resuscitation care. This is very easy to do with a digital version. We thought we want to address the expert. I think it was Marshall who said the aim of the cognitive aid is to help experienced teams to excel, and not the novice to do things for the very first time or something like that. And we found that a very helpful statement, which helped us actually creating the app. So what we did is we always said consider. We know that the cognitive aid is blind for the context, in contrast to emergency checklists in an aircraft. So it's again like the senior colleague saying, well, could this be an option? Did you already consider that? And if you go through and say, yeah, I thought about that. Oh, that's a good idea. I forgot it. And at the same time, you always have additional information. So at 3 o'clock in the morning, if you don't know how to dosage RTPA, then you just can open it. Or if you don't know which the contraindication for thrombolytic therapy are, you can go there. Many of the emergency manuals or the books you buy, they have the problem that you actually have to add a lot of local information by hand. So what we thought is that we would like to have on different parts of the checklists spaces where the user actually can add phone numbers, storages, procedures, how we do things at our hospital, and implement it into a local version. So every hospital can register for free, register because we don't want to have 2 or 3 highly motivated people from the same hospital applying for the same checklist, and suddenly you have 3 versions. And they receive an editor, and there they have a default a list with default values, and they can change them. And as soon as they save their changes, it appears on every app from there, or on every app which has made itself accessible for the local information, which is an 8-digit code. And suddenly you have your Harvard version or your Erlangen versions. And finally, yeah, this is the editor, and you go on the fingerprint up there, and then you can enter an 8-digit code, and then you suddenly have a local version. And the third thing is that we wanted to say, well, how can we support teamwork or resource management? So if we start with immediate measures with the team, found those 2 questions: do the team members know each other? Who is the team leader? The most important. In diagnosis, we thought that it might be very helpful to remind people to share the working diagnosis with the team, especially team leader, and to encourage people to voice their doubts or concerns to the working diagnosis. And in therapy, just to remind people that it's essential that the workload is distributed adequately, asking people whether everyone knows what his or her task is, and then, of course, 10 for 10, reevaluate the situation, what speaks in favor of, contradicts the working diagnosis. So the hope was, whenever you go through it and you read these CRM impulses on the right side, and people take it in and hopefully start to live these kind of thoughts. Good. Okay, so that's a very quick ride through the key features of the cognitive aid.
So when you talked about adopting or embracing the branched design, you have done it in spades. It looks as though there is a branching logic to get to the specific age that involves the patient's age, the presentation, the stable, unstable, and even the nature of the provider. So you're undoubtedly familiar with those simulation trials of cognitive aids that have been published that generally follow the pattern of use the cognitive aid and measure the number of critical steps completed and or the interval to completing those steps. So that gets to the question I previewed with you a moment ago, which is to what extent has that kind of trial of this tool taking place, either in isolation or in comparison with, for example, a paper-based tool. It's the comparison that would inform a choice about whether to follow your lead in branched logic, highly digital technical tool, or kind of the old-fashioned paper volume.
So at the beginning, when we planned this project, we had firm intention of actually doing a big simulation-based study with about 80 or 90 scenarios to actually evaluate the app before we launched it. More with the intention of getting feedback as far as the user-centered design process is concerned, but also on how it works and how people actually manage to manage a critical case. We never had the intention to compare it with a paper-based version because having read all the literature, we thought that it's not a worthwhile idea pursuing, because the main thing is not the tool, not whether you use a digital or a paper-based cognitive aid. The main thing is whether or not you invested a lot of implementing and training the entire team and actually sustaining this effort of using it. And as we just said before we opened the session, if you have a paper-based checklist and everyone is familiar with it, this is such a great asset. Think twice whether to replace it with a new version, because it changes the way you work, or it could change the way you work, and you really have to consider firmly whether or not this is a good way to pursue. So unfortunately, when we started these simulation scenarios, COVID hit us, and suddenly we were unable to gather to do sim studies, and we only were able to restart them last year. So we are still in the process of evaluating the data. But to answer your question, no, we did not think it's a good idea to actually compare it, because whether or not people, or how successfully people manage a case is not the question of a medium. And as you saw from the presentation, you had those lines with an item per line, and you can put your finger on it, you click it, and it gets a bit gray. So why should it be more difficult to go from bottom down, from top down to go through all your items. Why should it be more difficult with a paper-based one? So I guess
I'd underline the point you have made a couple of times about the I like to say implementation is king, and whether it's implementing this kind of tool or another, just putting it on the smartphone or on the wall doesn't really do very much. It is and you had mentioned that part of the work product of the working group was educational material, and maybe you can tell us a little bit about that. I mean, for example, the first time you use this, you probably don't necessarily know that there is this process of getting to the checklist that's right for the moment, or you pointed out some color coding, which the first time I opened this, I would have no idea what color stood for what. So what have you delivered, and to the extent what have adopters around Germany actually done for implementing? Because there's a difference between what's available to support implementation and what is actually utilized.
So actually, one of the of our cognitive aid team, Henrik Eismann, is online as well, who did a tremendous job of actually providing all the educational materials. So it's a very a vast array of materials, starting from what is actually cognitive as presentations, either PowerPoint or even as a video from a speaker actually presenting those. So you have to download the video on how to use it, what is teamwork, and then also in detailed presentation on how to actually use the key features. Plus scenarios pre-written if you have a sim center and you would like to have the team train that, so you just can take them off the shelf and use those scenarios. Plus PowerPoint low fidelity scenarios where you have screenshots from vital monitors and a case study, and how could you use the cognitive aid. So a lot of different ways people actually could train their team. We have instructions, what we think is important, which is that you always should try to gather a bigger team, nurses, plus anesthesiologists, plus physicians. Never try to do it alone. Try to get the support from the head of the department. Do a thorough implementation and training process before you start actually with the app in your operating theater. And a lot of material on the websites, but it's always astonishing. We always receive emails actually asking, why can't I download it in an Apple store? You say, oh man, you just have to read, but apparently people don't read websites and all the information. So it's there, it's out there if you can read German. And there's a lot what people actually can.
All right, so I'm going to ask this one more question and then open it up to the group. I see a couple of questions in the chat already. So those on the line, get ready to either raise your hand or enter something in the chat. And my question is, what level of information technology support is required for an institution to implement this tool, and is that a barrier for small institutions or ambulatory surgery centers or other sort of settings beyond the university medical center to do this?
So the only support you need is that the IT department allows you that you can access this URL. This is everything. And that you actually have the admin rights to install it on the surface of your PC. That's all.
Very good. And has the tool been implemented in a variety of settings, university centers, community hospitals, et cetera?
So the only number we have are hospitals who have registered, because they said we want to have a local variation or version of the app, and there's about 90 hospitals. But if someone downloads it and does not create a local version, we don't know it. There are many
Okay.
100 accesses per day on the server.
Very, very good. So I'm going to take Angela Enright had asked the question on probably lots of people's minds. That is, when do you anticipate the full tool in English language version will be available?
Not at all. If none of you has the interest of actually creating such a version. So, as I said, we created this English test version with a rudimentary content only to convey the idea on how to use this application. Our experience was, at least for the German setting, and as far as understanding also for the European setting, that it's absolutely powerful if the Professional Association of Anaesthetists or your scientific institution actually endorse and promote your cognitive aid openly. If there's only one or another hospital saying, well, I do my local version, chances are not very high that you actually can have a big spread throughout the country. So what we would like to offer to any country, because you can actually translate this app to any language. For example, the Austrian, also the Swiss Association of Anaesthetists have joined are using eGENA right now. And the Swiss have the problem that they have French-speaking anaesthetists. So they are already working on an app which is not called eGENA, but Assidu, et cognitive digitalisé d'urgence en anesthésie et réanimation. And of course, they would love to have people from France saying, well, this is our language, and we create a national version. And
yeah,
whoever you are listening from it, if someone says, well, I would like to create an English version, knowing which local guidelines and recommendations apply to my country, then we would love to share it for free. The only costs which you have are for the IT company for annual maintenance and creating your own national version.
Okay, so there's the global invitation to share the architecture or the technical framework. That's great. Barbara Burian, I saw you entered a question in the chat. Would you mind unmuting and asking Michael?
Sure. So Michael, I'm interested in how people navigate through the app. You've got lots of tabs and, check boxes and whatnot. In particular, I'm curious about your CRM tab. And it appears, although I'm not sure if it's absolutely correct, it appears that the content on the CRM tab changes based on which of the major tabs on the left you've selected. So immediate measures, diagnosis, or therapy. It appears that the CRM content changes. Is that correct?
That is correct, yes. And actually, after we had created the structure of the cognitive aid, we read the paper you wrote with Anna Kleber, the two papers from 2019 and 2020 on matching design to use and the effect of cognitive aid design, linear versus sampling. And this actually confirmed our idea that it's much more helpful for anesthetists actually being able to go to addressing a specific question. Because part of the user design process was that we had to clarify how do we actually work and how and when would we in the cognitive aid work group actually would use a cognitive aid. And our answer was, well, it depends. Sometimes you could start parallel to the event because you have enough people. And our app actually allows to go from left to right, from immediate measures, diagnosis, therapy. But sometimes you just have questions concerning the diagnosis. You're not sure, well, I think it's that, but how do you actually verify it? Or you have questions concerning therapy or differential diagnosis. And a straight linear design would always imply that I, as the architect, know what the user wants, and that's certainly not the case. So,
yeah. Does the content on the other tabs, symptoms and differential diagnosis, does that also change based on which of the primary tabs you've selected?
No, these are independent. So even you can, symptoms and differential diagnosis are independent because we thought from the way we as anesthetists works, you say, I'm not quite sure. Let's see whether the symptoms match what I find, or it's not quite the clinical picture I would imagine with disease A. Let's see which other differential diagnosis could have a similar appearance. It's early in the morning and my mind is blank.
Mm-hmm.
So we thought that those, which here on the slide are on the right, those two tabs, symptoms and differential diagnosis, are independent of the workflow we as anesthetists take.
Okay, thank you.
Welcome. And thank you very much for your work. It was highly inspiring for our working group.
Well, thank you. I'm looking at the list of people on this call, and everybody's work is inspiring to me. So this is great. Thank you very much.
Thank you. Other questions? It says raise your hand or put something in the chat.
We have a question from James Nelson. He notes that the Stanford manual or other manuals are widely used in the US and Canada, and wondering what additional value the eGENA app provides. He also asked a little bit around use fees, but I believe Dr. St. Pierre, you mentioned this already, that you would offer it free to any system or hospital that would like to modify and implement.
Well, currently we only think about offering to national societies, knowing that in America or in Canada it might be different because you have those big players, but that's not the case in our countries. Additional value, as I already said, if you have a cognitive aid that works, you want to support your team. And if the tool you have right now so does this job, then it's what you want more. If you have the choice of actually implementing something, I would say that a digital version, which takes all the work away from the user and which allows updating things with ease and modifying things. Every time a new guideline appears, we go through it and see whether or not the content has changed, whether there are new recommendations. We change it, and the user doesn't even notice it. Next time he opens it, the app checks, is there any new content? Sees yes, it downloads it, and you always have a new thing. So as someone being responsible for all these, the dissemination and having things up to date, it's of course much less work. But as I said, it's not a tool. There are no technical solution to social cultural problems. I think that's the truth.
Well, so I mean, I think it is fair to say that sort of printing, binding, distributing, updating, that kind of work, the care and feeding of a static manual is something that is absorbed by the working group. But the meaning of the word user here is important, because the local champion is relieved of those duties. And my line of questioning earlier was, does the frontline rank and file user taking care of a patient pick up additional work to use a complex digital tool? And so I just wanted to highlight that user in this context can mean different things. There's no doubt that what you say about the local champion or manager of the tools has an easier job because you're doing their work for them.
Yeah.
The related question is, what's the end user experience in the work of using the tool, and does the additional work, is it justified by the advantages that you've demonstrated brilliantly here? Other questions?
One thing you asked in the draft you sent to me might be also of interest. This is a question about the clinical guidance and how much is drawn from published practical guidelines and how much is just a result of our peer discussion. So I just wanted to show when we thought about which evidence could we actually implement, we recognized that there might be 4 different categories. One is that we have guidelines from anesthesiology, from our societies, who specifically address intra or perioperative emergencies like malignant hyperthermia, local anesthetic, systemic toxicity. Then you have guidelines, fantastic guidelines, like how you treat a myocardial infarction, how do you go with a pulmonary embolism, but you have to translate it into how we as anesthetists do our work to be of help. And then you have emergencies where there is no recommendation or guideline available, but other great minds already had thought about it and have created cognitive aids, like those you, for example, shared with others. And then you have recommendations or guidelines, no guidelines at all, but the clinical problems, like I suddenly inject a wrong drug into an arterial line. So what do I do next? And you have a lot of reviews or consensus. So what we do is, or what we did is, on the home pages, you can always download a current version of the medical content levels of evidence. The color coding is, again, the color coding from these 4 different categories. And if you, for example, want to see what we took as a therapy for intra-arterial injection in adults and in children, you see those 2 review articles in the upper right. Or, for example, at the end of the last year, we added pages to the management of tracheostomy and laryngectomy airway emergencies. And there you see where the recommendations are taken from, just to create a bit more transparency for people who say, well, I don't trust those guys, where do they take it from? It's all in the web if you take the effort and just look it up.
Very, very thorough. And actually, the breakdown of the sources of evidence is probably better than most published practice guidelines. Just my off-the-cuff editorializing there. If there are no further questions, maybe Jim, you can brief us all on accessing the recording of this and review resources on emergencymanuals.org.
Happy to. Thank you again, Dr. St. Pierre. What an honor to have you here to share this with our community. And the beauty of having it recorded is we get to share it online for anyone that missed it today. So within the next week, we will be processing this and getting it published on the Emergency Manuals website, emergencymanuals.org, and will be available on the webinars tab. We'll probably also make it available on the homepage for a short time, and feel free to share that with any of your colleagues around the world. We're looking to also get other speakers involved with this webinar series. So if anyone on the call has a interest in participating in a future webinar, sharing your work, please reach out to myself or Dr. Hannenberg, and we'd be happy to discuss opportunities for future webinar topics. If there are any topics that you'd like us to specifically bring to an EMIC webinar, we're also open to discussing opportunities there. We'll also be in touch for future webinars, and as well as future updates to the tools that are on the site. And we will also be in touch coming up in the fall for the ASA in San Francisco. That's all I have, Alex, if you want to close things out.
I will only close things out by offering my heartfelt thanks and also congratulations to Dr. St. Pierre and his colleagues in the working group for really an extraordinary piece of work. I am eager, in addition to looking for volunteers for future webinars, love to find volunteers for English language translation of eGENA.
Yeah, me too. That would be great, yeah. Or any other language. French people, for example, we're still looking for someone helping the Swiss colleagues, so that would be cool.
Great. Well, thanks all for joining. Enjoy the rest of your day or evening, as the case may be, and look forward to seeing you soon. Thanks.
Thank you very much to the two of you for inviting us.
Pleasure.